A very good day to everyone. We are from Group 6. We'll be presenting case study 6. I'll introduce our group members, Najwa, Izwan, Diana, Shahira, Amy, Mechi, Gavin, and myself, Shalini Priya. So here's our case study scenario. 30-year-old Madonna is a housewife who always very thirsty over for some years. She reports chronic intense thirst and excessive drinking polydipsia with polyuria. She's losing weight, has dry mucous membranes and skin even though she drinks large quantities of water and juice all day. Her excessive fluid intake and a constant need to urinate even at night, nocturia, make her constantly tired and irritable. A sample of Madonna's urine was tested for glucose. This test proved negative. A blood sample was sent for determination of plasma ADH, which appeared to be within normal limits. Her 24-hour urine volume was 6.5 liter. Following a water deprivation test, Madonna's urine was found to have an osmotic pressure of 460 milliosmol kilogram. Pathophysiology and signs and symptoms of the patient. First symptom is the polydipsia. It's a term used to describe excessive thirst. It can be caused by several factors like diabetes mellitus. High blood sugar increase the blood osmolarity and result in chronic water intake. In diabetes insipidus, the abnormality of kidney or pituitary gland can interfere with the ADH function and also water reabsorption, and it can cause excessive free water excretion. Apart from that, loss of fluid from bloodstream into the tissues due to sepsis causes the polydipsia. Psychogenic polydipsia is a kind of mental disorder that causes the compulsive water intake. Next symptom is polyuria, which is the excessive urine production. Hyperglycemic conditions causes the osmotic diuresis. That means when the glucose in the blood accumulates in the kidney tubules, it reduces the water reabsorption and also result in glycosuria, and eventually it increases the urine output. In diabetes insipidus, the abnormality of the kidney or pituitary gland interfere with the ADH function and causes polydipsia. And also during pregnancy, mothers can get gestational diabetes insipidus, which will subside after pregnancy. Excessive cortisol in Cushing syndrome can inhibit the ADH and can cause excessive urination. Hypercalcemia affects the kidney's response toward ADH function and also result in increased urination. Other factors like anxiety, alcohol, caffeine, kidney or liver failure affect the response or production of ADH function. Loss of weight can be caused by dehydration. Loss of water can reduce the total body weight. In diabetes mellitus, insufficient insulin prevents the body from getting glucose from the blood for the body cells to be used as the energy. Hence, the body starts burning fat and also the muscle, causing a reduction in total body weight. In diabetes insipidus, excessive loss of water through the polyuria causes loss of weight. Viral infection or parasite infection also causes loss of weight through loss of body fluid and also by absorbing the body nutrients. Other factors like cancer and medication also cause loss of weight. Next is nocturia. Nocturia is the urge to urinate at night. High water intake in diabetes mellitus, diabetes insipidus and also gestational diabetes insipidus causes polyuria. Edema of lower extremities. When the patient lie down, the extra fluid will be returned to the vascular system and kidney will be excreting the excessive fluid. Sleeping disorder like obstructive sleep apnea causes nocturia, and other factors like drug and alcohol or caffeinated intake before going to sleep can cause nocturia. Next is skin and mucous membrane caused by dehydration in diabetes insipidus, diabetes mellitus, alcoholic drinks. All this causes excessive loss of water, so it will result in dry skin and mucous membrane. Class 1 is diet and irritable. It can be due to not getting enough sleep because of nocturia. It is one of the symptoms of hypernatremia as well and can occur in diabetes insipidus, diabetes mellitus due to polyuria and dehydration. Hormonal causes like in PCOS and also hypothyroidism due to increased metabolism. That's all.
Hola everyone, my name is Diana and today I will present about the laboratory investigation findings of Madonna, our patient. There are 4 laboratory tests that were performed. First is the urine investigation. Second is the blood sample investigation. Third is the 24-hour urine sample investigation. And lastly is the water deprivation test. First, I will talk about the urine investigation. The urine sample of Madonna was taken to the lab to be tested for the presence of glucose. Why they are tested urine sample of Madonna for the presence of glucose? This is because, according to Mayo Clinic 2018, Madonna showed the symptoms of diabetes. The symptoms of diabetes is polyuria, constant need to urinate, excessive thirst, irritability, and also tired. So these symptoms of diabetes lead to the test of urine investigation, and the result is negative, means there is no presence of glucose in her urine. It indicates that no presence of glucose in her urine, so we can exclude diabetes mellitus, and she may suffer from diabetes insipidus. Diabetes insipidus has many types. First is the central diabetes insipidus. Second is the nephrogenic diabetes insipidus. Third is the gestational diabetes insipidus. And fourthly is the primary polydipsia. Okay, next, I will present to you about the blood sample investigation. Her blood sample was sent to the lab for the determination of plasma vasopressin, which is ADH or antidiuretic hormone. The result of her blood sample investigation showed that ADH level is within normal limits. It means that her ADH level is within 1 to 5 picogram per mil. Okay everyone, now I want to ask you, what is ADH? According to Arushikana 2019, ADH or antidiuretic hormone, or known as arginine vasopressin, is produced by hypothalamus, and it functions to regulate and balance the amount of water in blood. So, how ADH regulates the water in our blood? There are 2 situations. First situation is when there is increase in plasma osmolality and when there is decrease of vascular volume. So it will lead to activation of baroreceptor, which is located in the walls of aorta and carotid arteries, and it will activate the osmoreceptors in the hypothalamus. The activation of osmoreceptors will lead to the release of AVP or ADH release. The ADH have action on the vascular system and also on kidney. So how ADH acts on the vascular system? It will increase the peripheral resistance in the vascular system and eventually will lead to the increased fluid volume. Then the release of the ADH also action on the kidney by increase the water retention. But how? By increasing the ADH, it will increase the transcription and insertion of aquaporin 2 channel to the apical membrane of DCT and CD cell. DCT is distal convoluted tubules and CD is collecting ducts. So it will cause increased permeability of DCT and CD cells to water. And eventually, it will increase the fluid volume. And then, the activation of osmoreceptors also will increase the thirst center in the hypothalamus. Thus, it will increase the fluid intake. And eventually, all of these action will increase the fluid volume and decrease the plasma osmolality to normal level. Then next, I will talk about the second situation. which is decrease in plasma osmolality. In this case, the ADH release will be inhibited. Then, it will cause decreased number of aquaporin 2 channels inserted into apical membrane of DCT and CD cell. Then it will cause reduction in amount of water reabsorbed. Eventually, this action will cause the increase in plasma osmolality to normal level. Okay, that is how ADH regulate the amount of water in our blood. And next, I will talk about the 24-hour urine sample investigation. Madonna 24-hour urine sample investigation result show that she have a high volume of urine output, which is 6.5 liters, because it is exceed the normal volume, which is 0.8 to 2 liters per day. So it indicates that Madonna have abnormally high urine volume because of polyuria. So polyuria indicate nephrogenic diabetes insipidus, central diabetes insipidus, diabetes, or high fluid intake, or use of diuretic medication, or kidney disease. Then, lastly, I will talk about the water deprivation test. Water deprivation test is the semi-quantitative test to ensure adequate dehydration and maximal stimulation of ADH. It is performed with patients that may have diabetes insipidus. And Madonna result of water deprivation test is it show that osmotic pressure is 460 milliosmol per kilogram. And then next, I will talk about the water deprivation test and how it is performed. First, the fluid deprivation will be initiated, where we will inhibit the fluid intake. Then secondly, we will measure the urinary osmolality and the body weight hourly. Then, if there is no difference within the two results of urinary osmolality, we can stop the test and measure the urine osmolality. If the result of the urine osmolality show less than 300 milliosmol per kilogram, the patient may suffer from central diabetes insipidus or nephrogenic diabetes insipidus. But if the patient have urinary osmolality that more than 750 milliosmol per kilogram, the patient may suffer from primary polydipsia. But if two sequential or two results of urinary osmolalities have difference by less than 30 milliosmol per kilogram, or a body weight decreases by more than 3%, so we should administer her 5 units of aqueous ADH or desmopressin subcutaneously. Then we will measure her urine osmolality after 60 minutes later. Then, if the results show that her urine osmolality is more than 750 milliosmol per kilogram, she may suffer from central diabetes insipidus. But if there is no rise at all in her urine osmolality, even after administration of ADH or desmopressin, she may suffer from nephrogenic diabetes insipidus. Next, why is the patient showing signs of dehydration when she is drinking large quantities of fluid each day? This is because she is unable to retain sufficient fluid in her circulation. It can be shown when she has high urine output, which is 6.5 liter. So, usually in dehydration, ADH will be secreted more to induce thirst and reabsorb water from the collecting ducts. But in this patient, the ADH level was normal. So we can suggest that ADH unable to function normally, which is associated to nephrogenic diabetes insipidus. Okay, that's all for me. Then next, my friend will continue this presentation with suspected diagnosis.
Based on previous explanation by my friends about the sign and symptom and the lab finding for this patient, Miss Madonna, now I would like to explain about how to find about the suspected and the possible diagnosis for this patient, Miss Madonna. First of all, I would like to look at the sign and symptom for this patient. The patient is suffering from the intense thirst and the polydipsia, polyuria and nocturia, and the losing sweat and dry mucous membrane. Therefore, we know that the patient is more prone toward the diabetes mellitus and the diabetes insipidus. What is diabetes mellitus? Diabetes mellitus is the metabolic disease that causes high blood sugar due to not sufficient or effectiveness of the insulin products, whereas diabetes insipidus is the rare disorder that occurs when a person's kidney pass an abnormal large amount of urine that is insipid. The meaning of the insipid urine means that the dilute and the odorless urine. Before we look detail into the lab finding, we look about the mechanism of the polyuria. Because the mechanism of the polyuria is different between the diabetes mellitus and the diabetes insipidus. We look at the diabetes mellitus first. So when they are increased in the blood glucose, will increase in the glomerular filtration rate of the glucose. Therefore, will increase the osmotic pressure of the renal tubular fluids, then lead to the water retention in the renal tubular and decrease the water reabsorption, therefore will increase in the urination. Then the mechanism is known as osmotic diuresis. At the same time, the glucose will export together with the water, then lead to the urine known as glycosuria, that is the urine that have a presence of the glucose. Whereas for the diabetes insipidus, when there are problems in the hypothalamus or problem in the aquaporin 2 or vasopressin B2 receptor, then lead to the kidney insensitivity toward the ADH, or there are low production of the ADH. Therefore, there will be low or no water reabsorption. Therefore, increase the net loss of water and increase urination, and this lead to the production of the polyuria. Then we look more detail into our lab finding. When there are 24-hour urine that is a large volume with 6.5 liter, we can find that in diabetes mellitus and the diabetes insipidus. Whereas for the glucose test, the diabetes mellitus will show that there is positive result with the presence of the glucose in the urine, whereas the diabetes insipidus show that there is negative result with the absence of the glucose in the urine. So from the test here, the glucose test show that there is negative result. Therefore, we know that the result is more prone toward the diabetes insipidus. Then next is about the water deprivation test. The water deprivation is mostly carried out to diagnose the presence of the diabetes insipidus. The osmotic pressure is equal to 460 milliosmolar per kilogram. From the diabetes mellitus patient, they will be sensitive toward the desmopressin. Therefore, the result will show that the lower osmotic pressures. Whereas for the diabetes insipidus patient will show a difference and varies range of the osmotic pressure of the patient toward different diabetes insipidus. Therefore, from the result here, we know that the result will be more prone toward the diabetes insipidus. So from here, we know that the result and the patient's result of diagnosis of the patient will be more prone toward the diabetes insipidus. Now we look detail into the diabetes insipidus. Diabetes insipidus can be divided into 4 types. The first one is the central diabetes insipidus. The central diabetes insipidus is the damage to a person's hypothalamus or pituitary gland, then cause disruptions in the normal production, storage, and the release of the ADH. So the ADH level will be low. Then next one is the nephrogenic diabetes insipidus, or also known as primary polydipsia. The patient will be defect in the thirst mechanism at the hypothalamus. Then abnormal increase in the thirst and liquid intake that will slow down the ADH secretion because our body don't want reabsorb water anymore. Therefore, the ADH level will be low. Then next is the gestational diabetes insipidus that occur only during pregnancy. The abdomen by the placenta will be breakdown the ADH, and the prostaglandin level also will be higher in the pregnancy lady that will reduce the kidney sensitivity toward the ADH. Therefore, the ADH level will be low. Then next one is the nephrogenic diabetes insipidus. The kidney does not respond normally toward the ADH due to the vasopressin 2 receptor or the aquaporin problem. Therefore, the ADH is in the normal range or not affected. Then, based on our left finding, the blood test ADH show that is at the normal range. Therefore, we can know that our suspected diagnosis and requirement for the further confirmation is nephrogenic diabetes insipidus.
Okay guys, after several hundred years of not seeing me, here I am. So I'm going to present on the laboratory approaches and the investigation for the suspected diagnosis. I don't know why I'm wearing my earphones. Okay, never mind. So the first test normally that we do if for a suspected diagnosis is the 24-hour urine and a urine specific gravity test. We want to confirm what type of polyuria is it, and like if it's polyuria and urine osmolarity. So on day 1, the patient normally urinates into the container right after waking up, and he urinates every subsequent in the next 24 hours. So to collect the urine, it has to be midstream for the specific gravity test. So keep the sample in the refrigerator during the collection period, and then measure the total volume of urine and urine osmolarity. So attached here is the reference ranges for normal range of total urine, normal range of urine osmolarity, and normal range of urine specific gravity. So for total urine, it's 0.8 to 2 liters. So if it's it's less than 2.5 liters, there's no polyuria. It's it's normal, not to say normal, but normal for no polyuria. So if it's more than 2.5 liter, that's a lot, right? So there is confirmation of polyuria. So for normal range of urine osmolarity, it's normally between 500 to 800. So if it's less than 300, there is suspected diabetes insipidus, and if it's more than 800, it's primary polydipsia or others. So for normal range of urine specific gravity, it's 1.002 to 1.035. It's a very small range. So if it's less than 1.002, it's diabetes insipidus. If it's more than 1.035, it's just a mild dehydration. Okay, next. Okay, sorry. So for the next test, normally we do a serum plasma test. Okay, so we check for serum sodium, the normal range for it, plasma osmolarity, and the normal range for ADH level. So hold on, yeah. Okay, serum sodium and plasma osmolarity. So this could assist with indicating the underlying polyuric state, and plasma ADH level can confirm the type of DI. This is a very important test. So the normal range of serum sodium is 135 to 145 millimole per liter. So if it's less than 135, it's primary polydipsia. If it's more than 146, it's central or nephrogenic DI. So for normal range of plasma osmolarity, which is 280 to 300 millimole per kilogram K. So it's less or equivalent to 280, it's primary polydipsia. If it's more or equal to 300, it's diabetes insipidus. So the normal range of ADH level is normally between 1 to 5 picogram per mil. So if it's less than 1 picogram, that's other type of diabetes insipidus. But if it's more or equivalent to 5 picograms per mil, then it's nephrogenic DI. So I'm pretty sure the people before me has already explained what is nephrogenic DI and central DI and all that. So you all should be fine, hopefully. Okay, I wonder if I make a joke if people will actually see this. Okay, never mind. Sorry for wasting your time. So measurement of plasma levels of copeptin. Copeptin is the C-terminal peptide of provasopressin that is co-secreted with ADH. So when ADH is secreted, copeptin is also secreted. So the advantages of doing this test is it can remain stable for days in plasma, and it can also be measured quickly. But the limitations, it cannot be used in every single patient that has suspected DI. So it can't be used in patients with sepsis, lower respiratory tract infections, COPD, cardiovascular diseases, AVP receptor antagonist therapies, bronchial carcinoma, patients who have been exposed to animal antigens, because some of these might, especially when it's exposed to animal antigens, it may increase the copeptin. So it's like false reading. So it's a misdiagnosis. So now here attached is the graph. So for baseline copeptin, if it's less than 21.4, it's and without prior fluid deprivation, this is a picomoles per liter. So the stimulated copeptin at a plasma sodium level of more than 150, if it's stimulated at more than 4.9, it's primary polydipsia. But if stimulated at less than 4.9, that means less than 4.9 picomole of copeptin is being released, then it's complete or partial central DI. So this is how much copeptin is released. And copeptin is, as I've explained, it's a peptide of provasopressin. Okay, so if it's more than 21.4 without prior fluid deprivation at all, that means naturally it's in there, then that's nephrogenic DI. DI is diabetes insipidus. Sorry. So this is the last test that we normally do, which is the water deprivation test and desmopressin administration. So the first, okay, before we go to the interpretation, these are the tests, the procedure of the test. So the preparation, dehydration, and the desmopressin phase. So for preparation phase, no thirsting. There is we check the electrolyte abnormalities if they are corrected first. The weight, BP, and your heart rate is measured. Baseline plasma osmolality, serum sodium, urine osmolality, and all of these are measured. So this is the first phase. You have to prepare before you administer the desmopressin, you see. So yeah, so it's okay. So the dehydration phase, so there is weight, BP, and HR. So these are measured every 1 hour because you are dehydrating yourself. So you need to measure this to make sure that it's done safely. So urine output, osmolality, serum sodium, and plasma osmolality is measured every 2 hours. And plasma copeptin is measured only at the end of the dehydration phase. So desmopressin phase, this is the most important phase. No, technically all of these are important, but this is the most the key phase. Okay, so 2 micrograms of that's a micro, right? Yeah, that's a micro. 2 micrograms of desmopressin is injected through in IV or IM. Patient allowed to drink and eat as usual. So the urine output, urine osmolality, all of these are measured hourly for 1 to 2 hours after desmopressin administration. Okay, so the interpretation is nephrogenic DI. The baseline plasma copeptin, because we are checking the copeptin at the end of the test, it's more or equivalent to 21.4 picomole per liter, and the AVP is more or equivalent to 3 picogram per milliliter. For central and nephrogenic DI, the urine fails to concentrate and results in excretion of diluted urine. So as you've noticed, these are the interpretations for what type of DI. So this is like a very important test. So for nephrogenic DI, it's ineffective due to the lack of renal response to its action. So if it's low urine osmolality. So next I'll be passing the patient's management for suspected diagnosis to Umi. So before I go, I have a pantun. 2-3 kucing berlari, jumpa lagi.
So, next is patient's management for suspected diagnosis. The patient's management for nephrogenic diabetes insipidus is by giving drugs, monitoring, and also fluid replacement. So, the first drug is NSAID. It is to inhibit prostaglandin synthesis. The function of prostaglandin E is to inhibit ATH-dependent water flow, to to suppress the adenylate cyclase, which is an enzyme that catalyzes ATP into CAMP, and also to decrease sodium chloride transport in the collecting duct. Thus, there will be no opening of AQP2 channel and there will be no water reabsorption. So, giving prostaglandin synthesis inhibitor treatment to the patient will enhance ADH-stimulated CAMP formation, increase medullary tonicity, and also increase medullary sodium chloride content. Increase medullary tonicity acting as a driving force to enhance water reabsorption. Thus, it will increase urine osmolality and also reduce water diuresis. The example of NSAIDs drugs is endomethacin. The second drug is thiazide that will take action on the distal convoluted tubule. Thiazide will inhibit the NaCl cotransporter in the luminal membrane, thus decreasing the chloride and sodium reabsorption. So, sodium reabsorption at distal tubule will be decreased, and also it will cause the decrease of extracellular fluid volume. Then, the glomerular filtration rate will decrease, and the proximal sodium and water reabsorption will be increased. So, less water and sodium are delivered to the collecting tubules and less water is excreted, so less urine output. But the adverse effects of prolonged usage of thiazide is hypokalemia. The second patient management is by monitoring, giving low salt and also low protein diet to the patient to reduce urine output. The patient also must have balanced calcium and potassium. The next management is by fluid replacement. Patient must drink adequate amounts of water as soon as they feel thirsty, and patient also must drink enough water, are not likely to become dehydrated.
Hi, happy quarantine. So I'll be talking about the current trend on patient management in nephrogenic diabetes insipidus. So person who have NDI, they either have a congenital NDI or acquired NDI. So the management for congenital NDI, we try to treat the symptoms, while for in acquired NDI, in acquired NDI, we try to treat the underlying causes such as obstruction in urinary tract and so on. So in case that in acquired NDI we are unable to treat the underlying causes, we can imply the management that we do in congenital NDI into the patient with acquired NDI. So person who have NDI, they are very susceptible to have hypernatremia dehydration. So in terms of treating person who have hypernatremia dehydration in NDI and in normal person is rather different. In normal person, we can give them 0.9% normal saline, but in NDI, we are unable to do that because in a simple explanation, we see that the normal person's urine and a person with NDI's urine, normal person's urine have a balance between salt and water, but in NDI persons, their urine are essentially pure water. So when we say that urine are essentially pure water, where does the sodium goes? There is a retention of sodium in the person's circulation. So when we are trying to manage this kind of condition in NDI person, we can't give them 0.9% normal saline. Instead, we give them a hypotonic fluid. So talking about hypotonic fluid, we can give them orally or we can give them through intravenous administration. So if orally, we give them water or milk, while for IV, we give IV fluid, hypotonic IV fluid with 5% dextrose. So the main target of this treatment is to normalize the plasma sodium. Next, we can try to we can also manage them by giving thiazides and potassium sparing diuretic, which is amiloride. The mechanism of action for thiazide have been explained previously by my friend. So thiazide have their own backside as well. So instead of giving thiazide itself, we give a combination between thiazide and also amiloride. Because giving thiazide is causing the person with hypokalemia, so we try to overcome this downside by giving amiloride, which is a potassium sparing diuretics. So what amiloride does is by blocking the ENaC stands for epithelium sodium channel. So when this channel is being blocked, basically the sodium reabsorption into the secretion is being halted or reduced. When this is being done, it can prevent the excretion of potassium from circulation into the tubular fluids. So by that way, we can prevent hypokalemia in that patient as well. So basically, these are the current management that we can imply on person with NDI. The first one giving a hypotonic fluid for person with dehydration, while the second one giving thiazides and amiloride combination to manage their polyuria conditions. Next, I'll be talking about novel approaches for NDI treatment. So the first one is acetazolamide, which targets lithium-induced NDI. It helps to reduce polyuria and increases urine osmolality. In terms of its mechanism of action, it partially based on tubular glomerular feedback response and reduces GFR. So basically, it is showing the same effect and mechanism of action to thiazide and amiloride treatment. So it is known as alternative for thiazide and amiloride. As this is called as novel approaches, this drug is being used in mice, and it is showing better result as well as lower side effect compared to thiazide and amiloride. So in case that this drug is doing well in mice and in further studies, then it can be a better alternative to thiazide and amiloride sort of treatment. Next, talking about vasopressin analogs, known as VAL2 desmopressin. It targets towards NDI patients that have ASN 321 LYS mutation. As a result, this mutation causes the vasopressin receptor being expressed normally, but it has less affinity to vasopressin. So this approaches targets to use analogs, vasopressin analogs, that have higher affinity compared to the person's vasopressin, and this analog can induce the vasopressin receptor, and when it has been induced, the function will help the NDI patients. Next, talking about AVPR2 antagonists. Most NDI patients have AVPR2 gene mutation causing misfolding of vasopressin receptor V2R. So basically, for these novel approaches, the etiology is that the mutation causes misfolding of vasopressin receptor inside the person's cell. When the receptor is being formed, the receptor is misfolded inside the cell. So basically, this antagonist, AVPR2 antagonist, it enters the cell as it is highly permeable towards cell. It enters the cell, it functions as a chaperone. It binds towards the misfolded receptor. It corrects the receptor. When the receptor has been corrected, it can get back to its working position, which is the plasma membrane, and this will enable the function of the VR2 receptor. So basically, this antagonist binds to a misfolded receptor, corrects it, and by that way, the receptor can get back to its working position and emits its function. Next, I'll be talking about the secretin receptor agonist. Secretin receptor is expressed in target cells, which are the kidney cells. The agonists together with fluostatin can double urine osmolality in ABPR2 deleted mice, so it can function well in NDI patients since they are either having a distorted in function of vasopressin or in terms of the receptor, as this secretin receptor agonist is independent of vasopressin and its receptor. It can be a new approach towards the function on NDI persons. The treatment is, however, subject to adverse effects such as flushing of chest and face, since secretin and secretin receptor are also functioning in other parts of the body. If this sort of agonist is being introduced to a person, it does not only benefits towards doubling the urine osmolality, it is also causing other side effects, and the approaches is targeted towards in overcoming these sorts of side effects. So that's all from me. We'll proceed with my other colleagues. Thank you.
If a patient is producing a large amount of vasopressin from a tumor, from what symptoms are they likely to suffer? Normally, the vasopressin is produced from the hypothalamus, and the vasopressin is responsible in maintaining the osmolality in the body. Besides that, it has a powerful action in raising the blood pressure. In this case, the patient is producing a large amount of vasopressin, which is produced from the tumor instead of the hypothalamus. This event is known as the syndrome of inappropriate antidiuretic secretion, when there is an excessive levels of antidiuretic hormone is produced. This syndrome tends to occur in people with the heart failure or people with the diseases that are related to the hypothalamus. These are the several symptoms that will like to suffer for those who had produced a large amount of vasopressins in their body. Firstly, they will having an irritability, personal changes such as combativeness, confusions or hallucinations. Next, they will also having a seizures, sometimes stupor and coma. They will also have depressed moods or memory impairment. They also having a cramps or tremors, and lastly, nausea and vomiting.
The patient was having symptoms of frequent thirst and urination. The symptoms result from inability of the kidney to reabsorb water due to the resistance of the kidney to vasopressin. The kidney unable to reabsorb water properly, and water is lost through urination. Frequent urination or polyuria is a needing to pass high volume of diluted urine. The urine osmolality less than 200 milliosmoles per kilogram with the presence of polyuria indicates that the patient is having diabetes insipidus. The loss of water through frequent urination lead to the deprivation of fluid in the body and cause frequent thirst. The thirst prompts the person with diabetes insipidus to drink large volume of water. That's all from us. Thank you.